Hello everybody, welcome to DaVinci Academy's Chapter 4 on the abdomen, our Lecture 3, our anterior and posterior abdominal wall. So the anterior abdominal wall is a very important structure. It's a very complex structure that's important for both trunk mobility and as well as maintaining the structural integrity for the abdominal contents underneath. It is often divided into 4 clinical quadrants or 9 clinical regions. So the 4 regions, or the 4 quadrants, are often probably the most commonly tested and commonly used clinical quadrants, and they just compose of the right upper, right lower, and left lower, and the associated organs within them. And it's important to understand and to memorize kind of what structures are located where. Then the 9 clinical regions are composed of the hypochondriacs, the epigastric, the lumbar, the umbilical, the inguinal, iliac, or the hypogastric. So again, probably the most important ones to know are the epigastric, the umbilical, and the hypogastric. So in terms of these abdominal quadrants and these regions, it's also very important to note kind of where certain anatomical landmarks are located. So in terms of sensation and dermatomes, probably the most important ones to know are that right around this region right here, your nipple region is where T4 is, your umbilical region is T10, and then your inguinal creases right here is where you consider to be L1. And these are probably the most important surface dermatomes that are often tested, as well as up over here. This is where more phrenic innervation is, C3, 4, and 5. Often what's really interesting too is a lot of times this L1 vertebral location is often tested. It's important because it's where the anterior end of the 9th rib is located. It's where the transpyloric imaginary plane dissects and splits the pylorus of the stomach. At that same level is where you have the fundus of the gallbladder. You also have your celiac trunk and superior mesenteric artery, which kind of is the overall global understanding of where this may be above and below at this point. You also have the hilum of the renal vessels and the termination of the spinal cord, and usually what isn't considered to be an adult. So now we're going to go ahead and discuss the anterior abdominal wall fascia. The anterior abdominal wall fascia is a very high yield examination point as well as it is for a clinical point. The reason why is because this fascia continues from the anterior abdominal wall and continues into the lower anatomy of the legs, the perineum, the scrotum, and it's often important in pathological scenarios. As much as it may be a nuisance to try to memorize this, the continuations of these fascial compartments are very highly yield and very important to memorize. So the first one we're going to discuss is the superficial abdominal fascia. But before we do that, the first thing is to understand that you have your skin right here, and then this little yellow part right here, that yellow part is just the sub-Q. This is again. So you have your skin, you have your sub-Q, and then underneath that is where you have your first layer, your superficial fascia. So your superficial fascia is broken up into 2. It's broken up into, again, the superficial and the deep. So this lighter pink color right here is a superficial fascia, or called the camper. And this gets a little hairy and gets a little difficult, but the way that I remembered it is that when you go camping, you camp on the ground. So I thought, okay, that's the most superficial surface, so it's the superficial fascia. What's important is the superficial fascia continues down into the legs as a layer over the thighs as well as the pubis and perineum, and it continues to be the most superficial layer of the fascia in these lower anatomical structures. After your superficial layer, you have your deep superficial layer, or your scarpa's fascia. Your scarpa's fascia is very important too. Your scarpa's fascia, the way I think of it, is if this is the ground, this is your tent, you put these stakes in the ground to keep the tent there. So these stakes are what begins with an S, and scarpa begins with an S. I know it's a little trick, but that's how I try to remember it. And that's how I remember scarpa is underneath, or deep, and the tent or the camper is above. So deep superficial is scarpa, superficial is campers. So here are the continuations that are important to note, especially for scarpa. It continues as the fascia lata in the thigh. It continues as the Colles fascia in the pubis and the perineum. It continues in the penis as, again, just the generalized superficial fascia. And then it continues into the scrotum as the tunica dartos. And yes, again, I just want to repeat, these are all really important to note. Really, really important. After you have your deep superficial, you come up to the deep system, which is the deep abdominal fascia of the anterior abdominal wall. And this is important because it covers the anterior abdominal wall musculature and continues into the inguinal ring as the external spermatic fascia. It also continues into the buccal fascia. If you remember the old saying, the buck stops here. That's how I remember its use in the penis. The buck stops here, so it's the deepest layer. And it continues into the pubis or perineum as the deep perineal fascia. So again, this system goes skin, sub-Q, superficial, deep superficial, and then the deep system. So the muscular aponeurosis is composed of the muscular fascia that's associated with the anterior abdominal wall musculature. He continues medially over the anterior abdominal wall as the rectus sheath, and it's composed of the external oblique, the internal oblique, and the transverse abdominis, as well as, this isn't a muscle, but it's just a transversalis fascia, which is a continuation of a fascial plane posterior to all of these. So when we're discussing the anterior abdominal wall fascia, it's also important to discuss the anterior abdominal wall folds. There are 3 folds that contain either remnant structures or current structures. You have your median umbilical folds, your medial umbilical folds, and your lateral umbilical folds. The median contains the remnant of the urachus, and there's only one. The medial contains the umbilical arteries, and there's 2 of them bilaterally. And you also have the bilateral inferior epigastric vessels, which usually arise from the external iliac artery. And as you can see on the right, it kind of shows you in small print, but nonetheless it's there, small print where these are located. So median is going to be in the middle, medial is going to be just lateral to that, and then lateral is going to be off to the further side with the inferior epigastric vessels. So now we're going to go ahead and discuss the musculature of the anterior abdominal wall. So the anterior abdominal wall is composed of pretty much 4 muscles that help in trunk flexion, respiratory, and as well as just general mobility and anterior abdominal wall integrity. Pretty much the innervation of all these structures is from the associated and local intercostal nerves as well as regional lumbar roots. The first muscle we're going to discuss is the external oblique. It's the structure that is most visible externally. It originates from ribs 5 through 12, inserts into the crest, the aces, the pubic tubercle, and the linea alba. It's innervated by, again, the regional intercostals, as well as aids in flexion of abdomen and forced expiration. And the fibers ascend in a superior and external manner. So as you can see, they go up and out. And this is important, especially in a gross lab, identifying these fibers as they fan up and out like this. Those are going to be your external obliques. So while we're on the topic, as the fibers of the external oblique kind of ascend outward and upward, that's how I think of it. I think of the internal oblique fibers going in the other direction. So also going outward, but downward in this case. So upward and out, external, downward and out, internal. So the internal oblique originates from the lateral 2/3 of the inguinal ligament, the iliac crest, and thoracolumbar fascia. It inserts into T9 to T12, costal cartilage, pubic crest, pectineal line, and the linea alba. It's innervated again by the regional intercostals, as well as the lumbar associated nerve roots, and again aids in flexion and expiratory function. The transversus abdominis is the most anterior muscle that is located and originates from the lateral 1/3 of the inguinal ligament, iliac crest, thoracolumbar fascia, 7 through 12 costal cartilage. It also inserts in the linea alba, just like all of the muscles of the abdominal wall, pubic crest, pectineal line. Again, it's innervated by the regional intercostals and lumbar nerve roots and aids in flexion of abdomen and rib depression. Then you have the rectus abdominis muscle, which is the unique muscle that kind of gives you that nice, sexy six-pack abs look. It originates from the pubic symphysis and crest, inserts into the xiphoid process. It ascends bilaterally. It's again innervated by the regional intercostal nerves, and again aids in flexion of the abdomen and rib depression. As you may have noticed, the linea alba is a very important structure. It's a fascial point of insertion for all the anterior abdominal walls. And in Latin, linea alba means white. And as you may see in the gross anatomy, it is actually a white line. Another important structure is the linea semicircularis, or the arcuate line. The arcuate line is an important demarcation point to help describe how the rectus sheath is composed, both above and below the line. So now we're going to talk about it a little bit more. So the arcuate line, as I described, is this fascial demarcation point, and it is different above and below. So the rectus sheath is a continuation of the fascial planes of the muscles, as we described earlier. And it differs in what it's composed of above and below the arcuate line, both anterior and posterior. So I'm just going to explain it right here, and I'm going to try to draw and try to break it down. So anterior rectus sheath is composed of the external and internal oblique above the arcuate line. Now the posterior aspect of the sheath is composed of, again, the internal oblique, the transverse abdominis, and the transversalis fascia. And this is only above the arcuate line. Now below the arcuate line, everything is considered to be a component of the anterior rectus sheath. However, the posterior sheath is only composed of the transversalis fascia, and that's pretty much the biggest difference. If this is your rectus abdominis muscles right here, they're going to have a fascial sheath and plane above it called the rectus sheath, and there's also going to be a plane that supports it behind it. So however, it's going to be different whether it's above or below the arcuate line. So for clarity's sake, this is going to be our above, and then I'll draw the below. So above the line, you're going to have the external oblique come in and wrap around like this. You're also going to have the internal oblique come in and split into two and wraps around like this as well. And it comes around the anterior and posterior sides. Okay? You also are going to have your transversalis fascia and your transversus abdominis. So this is anterior and this is posterior. So anterior, you just have your external and your internal. Posterior, you have your internal, your transversus abdominis, and your transversalis fascia. Now we're going to talk about below. So below, the easiest way to remember it is that there's only one thing in the posterior aspect, and that is the transversalis fascia. And in my mind, everything is above. Everything is anterior, okay? So the above is more difficult, below is very easy. Below the arcuate line, all you have posterior is transversalis fascia, everything else is anterior. Above the arcuate line, your external and your internal oblique are the only ones on the anterior side of it. It may be difficult. If you need to go back and watch the slide again, I highly encourage it. But it's very important to know what is composing of the rectus sheath above and below the arcuate line. So now we'll discuss the vasculature of the anterior abdominal wall. The vasculature of the anterior abdominal wall is highly vascularized and contains many anastomotic vessels. Overall, the three primary structures that supply blood to the anterior abdominal wall are the internal thoracic, or IMA, the external iliac, and the femoral artery. The internal mammary artery gives off branches called the pericardiophrenac that supplies the diaphragm, as well as the superior epigastric artery that supplies the AAW. The external iliac artery, it branches into the deep circumflex iliac artery that supplies the iliac crest, and the inferior epigastric artery that supplies the anterior abdominal wall. The femoral artery branches immediately after it passes the inguinal ligament, and it branches into the superficial epigastric artery, which supplies pretty much strictly the cutaneous anterior abdominal wall. The anterior abdominal wall anastomos is a very important structure. It occurs between the superior epigastric artery and the inferior epigastric artery to provide blood to the rectus abdominis as well as the anterior abdominal wall musculature and skin. So the IMA descends and splits into the pericardiophrenac and the superior epigastric. What happens now, from the inferior side, you have your inferior epigastric vessels that come up, and you also have your superficial that also come up and just do skin. But it's between the superior and the inferior that you get this anastomotic point that's important for blood to all of this area. So now we're going to go ahead and discuss the posterior abdominal wall. The posterior abdominal wall has three important clinical applications. One, it's the site of musculature origination for hip flexion. It also houses the lumbar plexus, sacral plexus, and the associated cutaneous nerves, and it's also the posterior border of the retroperitoneal space. The posterior abdominal wall musculature is composed of four muscles. It's composed of the quadratus lumborum, which is a quad-shaped or four-sided shaped muscle that originates at the iliac crest and inserts into the last rib, the transverse process of the lumbar vertebrae. It's innervated from the nerve roots of T12 to L4. It assists in trunk flexion. The psoas minor is a very tiny, small muscle located above the psoas major. It originates from the vertebral bodies of T12 to L1, inserts into iliopubic eminence in the pectineal line. It's innervated by nerve roots of L1 and is a very minor contributor to trunk flexion. The psoas major is a very important structure of the posterior abdominal wall musculature, and it's important because it is one of the main contributors to hip flexion. It originates from the transverse process of T12 to L5, inserts into the lesser trochanter of the femur along with the iliacus as the iliopsoas tendon, and is innervated from the nerve roots of L1 to L3. The last, what is considered posterior abdominal wall musculature, which may not necessarily be posterior abdominal wall and more likely pelvic muscle, is the iliacus. It originates from the upper iliac fossa and inserts into the lesser trochanter as described before with the psoas major. It is innervated by the femoral nerve and aids in both hip flexion and medial thigh rotation. So in regards to the posterior abdominal wall musculature, there is a layer of thick fascia that separates the posterior abdominal wall muscles from the parietal peritoneal membrane. Infections can enter into this fascial layer and descend inferiorly, entering the pelvis or retroperitoneal space. For example, TB loves to descend along this fascial plane, along the psoas major, and is commonly called Pott's disease. What's also important to note is that there are more arcuate ligaments that are housed in the posterior abdominal wall musculature, which compose of the median, the medial, and the lateral arcuate ligaments. The median arcuate ligament is a site of abdominal aorta entrance into the abdominal cavity. The medial arcuate ligament is the site of the psoas major on the superior portion of the posterior abdominal wall, and the lateral arcuate ligament is the site of the quadratus lumborum as well. So the lumbar plexus is an important structure that originates from T12 to L4. It is formed from the ventral roots of the lumbar region and leads to the vertebral foramen of passing through the psoas major muscle. There are 6 major nerves that are associated with the lumbar plexus. The first is the iliohypogastric nerve, which originates from T12 to L1. It is responsible for motor innervation to the transverse abdominis and internal oblique, as well as provides cutaneous innervation to the lateral gluteal area and the pubic region. The ilioinguinal, which is L1, provides motor innervation to the transverse abdominis and internal oblique, provides cutaneous innervation to the lateral gluteal area and the pubic region as well. It passes in the inguinal canal, runs on top of the spermatic cord, but it does not exit the deep inguinal ring. It does not exit it. Then you have the genitofemoral nerve, which is from L1 to L2. It is responsible for motor innervation to the cremaster muscle in the scrotum. It splits into 2 branches. The genital branch, which provides cutaneous innervation to the scrotal skin, mons pubis, and labia majora, and the femoral branch, which provides cutaneous innervation to the upper medial thigh and runs underneath the inguinal ligament. Then you have the lateral femoral cutaneous nerve, L2 to L3, that has no motor innervation and is solely responsible for cutaneous innervation to the lateral thigh. Then you have the obturator nerve, which rises from L2 to L4. It is responsible for motor innervation to the medial compartment of the thigh, as well as cutaneous innervation to the medial upper thigh. The femoral nerve, which originates from L2 to L4, has many functions. It's motor innervation to the anterior compartment of the thigh. It also provides cutaneous innervation to the anterior thigh and lower medial thigh via the anterior cutaneous branch. It also provides cutaneous innervation to the anterior leg and the medial leg via the saphenous nerve. The sacral plexus is a network of nerve fibers that come from the nerve roots L4 to L5 and provides important innervation for the foot, the leg, and cutaneous sensation to the pelvis and lower leg regions. The nerves that branch off the lumbosacral trunk either exit the pelvis for extrapelvic innervation, or they may stay inside the pelvic cavity to supply innervation to the pelvic organ with the pelvic splanchnic nerves. The superior gluteal nerve, which arises from L4 to L5, comes off the sacral plexus. It exits via the greater sciatic foramen and innervates the gluteus medius, minimus, and the tensor fascia lata. Inferior gluteal nerve, which arises from L5 to S2, exits via the greater sciatic foramen as well. However, it only innervates the gluteus maximus muscle. The sciatic nerve is considered to be the largest peripheral nerve in the human body and is considered to be the most important structure for the distal leg innervation. It provides innervation to the thigh, the posterior compartment, anterior and posterior leg, and as well as the foot musculature. There are 2 divisions, the tibial and the common peroneal. The sciatic nerve has no direct cutaneous nerves. However, there is cutaneous sensation via the 2 divisions. It exits the pelvis via the greater sciatic foramen, inferior to the piriformis muscle. The sciatic nerve may vary in its exit, inferior, superior, or within the muscle belly of the piriformis, and can often be a site of entrapment, often referred to as sciatica. The tibial nerve, which comes from L4 to L3, innervates posterior thigh muscles, posterior compartment of the leg, and plantar surface of the foot. The common peroneal nerve, L4 to S3, innervates the short head biceps femoris, anterior and lateral compartments of the lower leg. Then you have the pudendal nerve, which originates from S2 to S4 off the sacral plexus. It's primarily involved in sensation to the perineum and anus. However, it does supply motor innervation to the pelvic floor muscles that can often be disrupted and damaged during childbirth. Posterior cutaneous nerve is another nerve that comes off the sacral plexus from S1 to S3. It provides cutaneous innervation to the posterior thigh, upper leg, and perineum, and its branches include the inferior cluneal and perineal branches. So retroperitoneal structures are very important, especially in pathologic or acute or traumatic settings. It is a space that is unique to the thorax, the abdomen, and the pelvic cavities. Retroperitoneal organs are either termed as primary or secondary, based on if they originate in the retroperitoneal space or end up there after fetal development. It's also important to talk about the mesentery. So the mesentery is considered to be a double-folded peritoneum that connects to the abdominal viscera to supply innervation and vascularity. The mesentery surrounds the intraperitoneal organs, but the retroperitoneal organs do not have a similar mesenteric system. Only the intraperitoneal organs have a mesentery. So in terms of retroperitoneal structures, the only primary structures include the kidneys, the adrenal glands, the ureters, the aorta, common iliac, internal and external iliac arteries, and the IVC. The secondary retroperitoneal structures include the duodenum, the pancreas, the ascending colon, and the descending colon. However, the duodenum and the pancreas are unique in that all of it is considered to be retroperitoneal structure. The first segment is intraperitoneal of the duodenum, and the tail of pancreas is also considered to be an intraperitoneal structure, as it's intimate with the spleen. The significance of the retroperitoneal organs is that during an injury or a bleed, it may have a difficult presentation, and it may be hard to localize where this bleed is occurring. This can result in significant life-ending amount of blood accumulating in the retroperitoneal space. So the linea alba, as described before, is a very important structure. It is, again, the central midline fascial insertion for the anterior abdominal wall musculature. It is also interesting to note that it can become pigmented during pregnancy. However, the important aspect is the linea alba is often avoided during surgical incisions, and that is because if you are unable to reattach the linea alba or you destroy its integrity, you may actually compromise the anterior abdominal wall musculature and actually weaken the musculature to a certain extent. However, the linea alba may actually be compromised in order to allow for specific surgical applications. So back to the whole idea of the arcuate line. As you remember, the arcuate line is important for understanding the anatomical relation of the fascial planes of the rectus sheath. So again, there's a difference between what's contained in the rectus sheath above and below the arcuate line. Below the arcuate line, the inferior epigastric vessels are actually not protected posteriorly because, as I mentioned, the posterior aspect of the rectus sheath beneath the arcuate line is only supported by the transversalis fascia. So what happens is if there's some sort of injury to the inferior epigastric vessels beneath the arcuate line, posteriorly, there's an increased risk of severe bleeding and a hematoma may form a significant amount of blood. The lower abdominal wall is actually very important for breast flaps and breast reconstruction, as well as also for other reconstructive defects. The high vascularity, as well as the potential for a clean dissection and the expendable myocutaneous nature of the lower abdominal wall, lends for very important use during reconstruction. The superior epigastric, the inferior epigastric, and the superficial epigastric vessels all play a role in flap coverage and distal defects. So there are different types of anterior abdominal wall flaps, and it's mostly important for plastic and reconstructive surgeons. You have the transverse rectus abdominis muscular flap, in which you actually will remove a portion of the rectus abdominis for breast reconstruction. So what these surgeons will do is they'll cut a football-shaped defect like this, in which they will either take muscle, they'll take fascia and skin, or just skin. And they will then cut it and relocate it to wherever the defect is. So depending on what is necessary, different types of flaps may be used, whether it's a tram flap, a deep flap, or an SIEP flap. There's also an important clinical sign called the psoas sign, and this is important when we're talking about appendicitis. So the appendix is a very small, tiny organ located in the right lower quadrant that can become inflamed or infected, especially when a fecalith or some sort of ischemic process happens to the appendix. When the appendix becomes inflamed and irritated, it may rub against the peritoneal lining and actually cause significant amount of pain at McBurney's point. An important test to see if appendicitis is acutely happening is called the psoas sign. This is performed by passively extending the thigh of a patient that is lying on their side with the knees in extension. If the appendix is in a retrocecal position, when you flex the psoas muscle, irritation of the appendix will result, indicating the presence of appendicitis. However, if the appendix is not naturally in a retrocecal position, this test may not indicate appendicitis, yet appendicitis may still be present. And that concludes DaVinci Academy's Chapter 4 section on the anterior and posterior abdominal wall.